Welcome to session 47 of the Falcon Physician Review Anatomy Online component. I think it's really important as we're getting close to completing the head and neck that you start looking for ways of pulling all of this information together with generalizations, patterns, and ways that you can manage large volumes of information. This will assist you not only in your preparation for the USMLE, but a long and healthy career in medicine. So let's move forward looking at the 5 generalizations of the head and neck that you may not have pulled together at this point. First of all, what are the 5 major areas that we're going to deal with that have 5 major nerves? That's going to be our next segment. Well, there's the orbit, the cavernous sinus, the nasal cavity, tongue, and the external and middle ear, all of which have 5 nerves distributing to those areas. And then finally, we are having the areas that we want to make generalizations about, which we can do with the larynx, pharynx, palate, tongue, and glands of the head and neck. And to end off, we'll stop with the 6 reflexes to consider in the head and neck. So let's start with the lacrimal gland, which is innervated by cranial nerve 7. The nasal glands, all of which are innervated by cranial nerve 7. The lacrimal is getting innervations from the communicating that's coming up from the pterygopalatine fossa, and the nasal glands are also getting parasympathetics that are coming from cranial nerve 7 as a result of the greater petrosal. If we get into the submandibular and sublingual glands, though, these are also innervated by cranial nerve 7, but they're coming in through the chordotympany branch on V3. So you can see glands below the corner of the mouth are done by the chordotympany branch, and glands above the corner of the mouth are done by greater petrosal branches. The parotid gland, on the other hand, is innervated by cranial nerve 9 through the otic ganglia, and it will come out onto the auriculotemporal nerve, which is a branch of V3. So what's the generalization we can make from this? The generalization is that all glands of the head and neck, except for the parotid, are done by cranial nerve 7, and the parotid itself is done by cranial nerve 9. Now let's look at the regions of the pharynx and the innervations there. We have a nasopharynx, oropharynx, and laryngopharynx. The nasopharynx is going to be behind the nasal cavity. The oropharynx is going to be below the soft palate but above the epiglottis, and it will include the areas known as the vallecula. And this area can be the portion that catches pills, or sometimes known as the pill box. The laryngopharynx is below the epiglottis and goes all the way to the bottom of the cricoid cartilage, which is at the level of C6, where it will change from the larynx into the trachea. Now, sensory innervation, the nasopharynx is supplied by V2 and mostly 9. The reason that you want some V2 going to the nasopharynx is so that you can elicit a sneeze reflex. So if you could get food above the soft palate, you want to exit this through the nasal cavity, because if you can't swallow it, since the soft palate goes up during deglutition, then it's going to be trapped there. The oropharynx is going to have innervation from cranial nerve 9, and that's going to be via the pharyngeal plexus. And the lower laryngopharynx is going to be innervated by cranial nerve 10 via the pharyngeal plexus. So each area has a basic innervation to it, but in general, most of that is carried through pharyngeal plexus. The piriform fossa, or recess as it's known, is on either side of the larynx in the laryngopharynx. And this is the area where fluids will flow around. If you're involved in drinking something quickly, or if you're swallowing something that's a stiffer bolus of food, it will push over the epiglottis and bypass the piriform recess. But this is a place where fish bones will sometimes get trapped, and all of this piriform recess is going to be innervated by the superior branches of the vagus the laryngeal nerves, and there's going to have an internal branch that will be coming through that area on its way to the larynx to supply sensation above the vocal cords. Here you can see a cross-sectional section of the head showing the nasopharynx, oropharynx, and laryngopharynx, along with some of the borders between those, which would be the soft palate and the epiglottis and the posterior cricoid cartilage. You can see the larynx anteriorly to the laryngopharynx, and you can see how the esophagus and the trachea will begin below that cricoid cartilage. Now we'll look at a couple of the constrictors. Here you can see the superior constrictor, middle constrictor, and inferior constrictor. And the generalization that you can draw from the constrictors of the pharynx is that they're all innervated by cranial nerve 10, except for one small muscle, the stylopharyngeus, which is innervated by cranial nerve 9. The stylopharyngeus will be involved in pulling up the pharynx during swallowing phases, so it will widen it. Therefore, the tongue can push a bolus of food back into the oropharynx, and as the pharynx relaxes, it will both drop and close around this and begin the peristaltic wave, which is actually somatically controlled until it gets into the esophagus. One of the clinical considerations for the pharynx is that you can get diverticula that are formative off of these things, and that's called a Zenker's diverticula, which is one of the weak points at the pharyngeal wall near the bottom of it. And it's that inferior pharyngeal constrictor where if this Zenker's diverticula occurs, you can get food accumulating in that pouch, which can cause dysphagia or regurgitation, and you can aspirate these things into the respiratory passage, which would give you an aspiration pneumonia or significant choking problems. And here you can see a Zenker's diverticula with the very enlarged pouch associated with hanging off of the esophagus at the level of the posterior constrictor, I guess. Now let's do a question. A 36-year-old woman is admitted to the hospital after a car accident with severe head injuries. During a neurologic exam, her uvula is deviated to the right. Which nerve is affected? Most of you should remember that the vagus nerve, when it's injured, and the uvula will point away from the site of injury. So if she has a deviated uvula that's going to the right, it must have left vagus nerve damage. And that is our answer. If it were the hypoglossal nerve that were damaged, it would go to the right side and you would lick your lesion, but this would be a tongue injury and not an uvula or palate injury. The glossopharyngeal nerve, remember, is essentially a sensory nerve and only does one small muscle, which does feed into the pharynx but not to the palate. Let's move on to the palate. Here you can see the aponeurosis of the palate, and there's going to be 4 muscles that feed into this, 2 from above and 2 from below. The ones from below will be the arches of the oral fauces. The palatoglossus, which will arch forward towards the base of the tongue, and the palatopharyngeus will arch posteriorly to the oroconstrictor. And in between, there's going to be a rich vascular network from 5 different blood vessels in total that's going to feed that tonsil sitting in between in the tonsillar crypt. So what's the generalization we can have with this palate? First, let's look at a couple more muscles that will make this up. There's the uvula muscle itself, which will hang down from the belly of the palate. And then there's the 2 superior muscles, which will be the levator palatini, which will lift up the palate, and then the tensor palatini, which is also innervated by V3 instead of cranial nerve 10 like the rest of the palate muscles. So the generalization we can make is that all palate muscles are done by cranial nerve 10, except tensor palatini, which gives innervation from cranial nerve V3. Now these tonsils around the palate will make what's called a tonsillar ring of lymphatics, oftentimes referred to as Waldeyer's ring. And the Waldeyer's ring includes two pharyngeal tonsils, which will sit up in the nasopharynx, and they'll combine so that there really only seems to be one pharyngeal tonsil. Once that pharyngeal tonsil gets irritated and inflamed, it's called the adenoid, but not until it's inflamed. Then we have the palatine tonsil in between the various arches that we just discussed, and the lingual tonsil, which again starts bilaterally but goes on the base of the tongue, which basically keeps those two looking like one combined tonsil. What is the Waldeyer's ring then? It's a ring of tonsillar tissue that will help present antigens directly at the oral cavity. The adenoids are going to be a popular term for hypertrophy of the pharyngeal tonsils, and this may obstruct the airflow through the nasopharynx, in children especially, or it can cause chronic mouth breathing. And here you can see some very inflamed palatine tonsils just prior to their removal in a tonsillectomy. These can cause a blocked auditory tube as well, which can impair hearing. Inflammation of the adenoids, known as adenoiditis, is common and readily spreads to the tympanic cavity through the auditory tube in children. This can cause otitis media, and that's the inflammation of the middle ear, and that can close down the tube and cause the scarring of the tissues. As well, because it's more horizontal and shorter in length, children will have a hard time equalizing the pressure between their middle ear and the areas outside of the middle ear. Now as we look at the muscles of the oral cavity, we want to see that we have the palatoglossus, which is innervated by 10. Then we're going to have the hyoglossus and the genioglossus and the styloglossus, as well as the intrinsic muscles of the tongue, of which there are 4 of them. So we can see all 8 of the oral cavity muscles, but only one of them is done by cranial nerve 10. The rest are all done by cranial nerve 12, the hypoglossal muscle. So the next generalization that we can make is that we have the all muscles with glossus in their name are innervated by cranial nerve 12, except for the palatoglossus, which is innervated by cranial nerve 10. And the way I remember this is all things of the palate being innervated by 10, and all things of glossus being innervated by 12. The palate rule comes up first, and you end up having palatoglossus done by cranial nerve 10. Let's go to a question. 2 children were pretend sword fighting with sticks, and one of the children pierced the other's muscular triangle just below the hyoid. You see that the thyrohyoid membrane has been damaged. What nerve is the most likely one injured by the stick? So this is going to be just below the hyoid, which means that it's going to be infrahyoid. It's going to be piercing through the thyrohyoid membrane, and the superior laryngeal nerve has a branch that will then come down and divide into an internal laryngeal and an external laryngeal. The internal is so named because it pierces through the thyrohyoid membrane, so this would be the answer because it's the one that's going to be closest to the piercing region. Now let's look at the compartmental spaces of the larynx and the innervations. If you look at this cross-sectional drawing with a frontal view, you can see that there is the yellow hyoid bone. There are blue cartilage, including the thyroid cartilage and the cricoid cartilage. There are green membranes running between the thyroid and the hyoid, known as the thyrohyoid membrane, and there is the cricothyroid membrane that runs between the cricoid and the thyroid membrane. On the medial superior aspect of that cricothyroid, it's known as the conus elasticus, and the very top of the conus elasticus has thickened and upregulated its amount of elastin fibers, which allows it to vibrate for years and years without wearing out. It's really just the more internal structures of the cricothyroid membrane. The hyoid is at the level of C3, and the cricoid is ending at the level of C6. So the entire larynx is between those levels. Below that level, there's going to be trachea, and more posteriorly in the pharynx region, it's going to be esophagus. There's a couple spaces that are divided by that level of the vocal cord. There is the supraglottic space, which will be above the glottis, and there's an infraglottic space, which will be below the glottis. The two spaces above the glottis include the vestibule, which is the waiting space, with the quadrangular membrane covered by mucosa. After it runs out of quadrangular membrane, the mucosa just slips in and makes the little ventricle, which is the second space. And that ventricle is pretty critical in order to space out the false and true vocal cords, but also to supply glandular secretions that will keep the true vocal cord during vibration from getting too hot and having protein breakdown. And this is what happens if people are doing a lot of talking or singing or something, and they'll vibrate and produce heat and end up with laryngitis. The infraglottic space is that space below the glottis, and that's going to include the level of the true vocal cords above the trachea. Here you can see the drawing that shows the different membranes and the actual ostia for the penetration of that superior laryngeal's internal branch. Now let's discuss the muscles and the movements of the larynx. Here you can see that there are three main movements available at the cricoids and the arytenoids. There's the tilt of the arytenoid, which will tilt in anteriorly and loosen the vocal cord by decreasing the pitch. That's called the thyroarytenoid muscle. Or more posteriorly, there's a muscle that will tighten the vocal cord and increase the pitch, and that is the cricothyroid muscle, which gets innervation from the external branch of the superior laryngeal. This one will decrease pitch. Now, the gliding action occurs when there is going to be an arytenoid that slides out laterally, and this will be abduction, and the cricoarytenoid muscle has a posterior cricoarytenoid and a lateral cricoarytenoid. The posterior cricoarytenoid will do both the sliding and gliding out by abduction, and then it will also do the abduction that occurs via rotation or pivoting around a central axis. What's going to happen with the reversal of these two actions is that you need to have the arytenoideus muscle to pull them together via the glide, and then you have the lateral cricoarytenoid as a muscle that's going to return them to the neutral position via the pivot. Let's discuss innervation in a graphic sense. We can see the same cross section. Now what we have to do is send down this vagus nerve, which will go around an artery in the neck, and that's going to become the recurrent laryngeal after it goes around either the aorta or the subclavian artery. And the recurrent laryngeal nerve is going to supply everything below the level of the vocal cords, both sensory and motor structures. Above the vocal cords, there's going to be an superior laryngeal nerve, which divides down into an internal and an external branch. The internal branch will pierce through the thyrohyoid membrane while the external branch will go to the cricothyroid muscle that will be on the external surface of the laryngeal cartilage. Even though it sits on the outside of the larynx, it's still considered an intrinsic muscle of the larynx because they are defined by having action on the vocal cords, whereas the extrinsic muscles of the larynx actually just move the whole entire laryngeal unit up and down. For instance, when you swallow, the whole larynx will move up, but when you phonate, you need to use things like the cricothyroid muscle and all of the other muscles associated with the larynx. So when you're talking about innervation, above the vocal cords, the superior laryngeal will come down and branch into an internal branch, which will be sensory above the vocal cords, as well as the piriform fossa, and an external branch which will go to the cricothyroid muscle. If you're below the vocal cord, the recurrent laryngeal is responsible for both motor and sensory innervation. So what you can see is that the recurrent laryngeal is going to run in that tracheoesophageal groove, supplying the trachealis muscle and the esophagus muscle with visceral supply as well. There are 5 generalizations that we've just made then, because here we can see that all larynx muscles are innervated by the recurrent, except for the cricothyroid muscle, which is innervated by an external branch of the superior laryngeal. Here you can see some clinical relevance of the larynx. If a sharp foreign object, for instance a fish bone, gets lodged in the piriform recess, that object can be removed but may damage the internal laryngeal nerve or the pharyngeal sensory branches of cranial nerve 9 or 10. In order to have a video capable laryngoscope to remove that, it will make it a lot easier to visualize the vocal cords. Cricothyrotomy is an emergency airway procedure where the incision or the needle passes through the cricothyroid membrane because there's very little in the road of that membrane, and it has a nice backstop with the posterior aspect of the cricoid as well. And then finally, tracheostomy is a hospital procedure. Here you can see the cricothyroid and the tracheostomy positionings, which can be done in an emergency situation. However, the tracheostomy tends to be surgical just because it's harder to landmark, and there can be significant vascular structures in around there, as well as the isthmus of the thyroid gland. So that concludes our 5 generalizations. Let's pull them together in summary before we move on. First of all glands of the head and neck are created and supplied by cranial nerve 7, except for the parotid, which is innervated by cranial nerve 9. All pharynx motor muscles are done by 10, except for the stylopharyngeus, which is done by 9. Then we have the third one, which is all muscles with palate in their name are done by 10, except for the tensor palatini, which is done by V3. All of the glossus muscles are done by cranial nerve 12, except for the palatoglossus, which is done by 10. And all larynx muscles are done by 10, with no exceptions. However, if you wanted to make that more specific, you could say that all of the larynx muscles are done by the inferior or recurrent laryngeal, except for the cricothyroid, which is done by the external branch of the superior laryngeal. That concludes our 5 regions with 5 generalizations, and now we're going to move into the next clip, which will be 5 regions with 5 nerves distributing to them.